Order, good afternoon and welcome to the Women and Equalities Select Committee. Today we're holding an evidence session on reproductive and menstrual health conditions among girls and young women. This does feel like on repeat because we were here about medical misogyny, which very much it touched on girls' health, but focused mainly on women. And actually, I think from that report, we discovered that if we get this right from an earlier age, then we can avoid some of the delays in diagnosis and treatment further on the line. So today, we're going to be hearing from a fantastic panel. We have Dr. Sue Mann, the National Clinical Director for Women's Health at the NHS England, and Professor Dame Lesley Regan, the Women's Health Ambassador for England. Welcome to you both, and thank you for coming. We've got a lot to get through, so I'm going to hand over straight to Alex.
Thank you. Do you both mind if I address you with first names?
Definitely. Very sensible.
Thank you. Lesley, I wonder if I could start with you. Briefly, what has been your proudest achievement as Women's Health Ambassador in relation to better supporting girls and women's menstrual and gynecological health? Just briefly.
Well, happily, I can say that in the last 3.5 years, I think we've made quite a bit of progress. We haven't gone fast enough or far enough, but then I'm a very impatient person, and I've been waiting a long time to get it better. But the same thing that I do want to say, though, is that to have a situation now where everybody knows what we're talking about when we talk about the importance of improving women's health, because it improves everybody's life in society, male or female, that's a big step forward, because that wasn't the case. If 5 years ago I'd invited a group of doctors to come to a women's health conference, they'd have said, well, what are you going to talk about? And I think now that we understand that, we've also, I think, got a very clear understanding, not just in healthcare professionals, but also in women and men in the community, our patients that we serve, that women's health is not just about reproduction and pregnancy and periods and the menopause, although sometimes if you look at the Daily Mail, you might not believe that. But the thing is that we've now understand that there are lots of things that are going to affect women disproportionately for a variety of reasons, and perhaps we could come back to that, because they are women and because of their biological sex and because of the phases and transitions they go through across their life course. So I think also the other thing I'm proud of is that we've got a much better understanding of how this is a continuum and that girls and women need to be looked after throughout their lifespan, across their life course, and that we can't, as a healthcare system, provide all of that. We've got a lot of other agencies and government departments to contribute to that, and a societal shift as well about helping oneself, and that's not putting the onus back onto girls and women. It's saying they need to be empowered. It's a rather overworked word, that, isn't it? But they do need to be empowered to know what they can do to improve their health and their longevity. Because my daughters, which I often repeat this point, my twin daughters are in their 30s now, and they are going to be the first generation of women who, without doubt, will live longer post-reproductive than they were reproductive. And that's never happened before in our society, apart from some people that we remarked, think, oh my goodness, she grew to a great old age. But that's going to happen, and the things that are going to be really important for us to understand and provide health services for are cardiovascular disease and the complications of MSK and osteoporosis and frailty and dementia. And I think we've got to now have a really big push towards getting everybody in society to understand that those are the big things that we've got to really improve.
Thank you. You've sort of touched a little bit on what needs to happen next, but I wondered if there are any areas where you're disappointed in terms of progress, or whether there could have been more removal of barriers, for instance.
Well, it's always easy to be negative about things, but I've got this incurable optimism streak, so I'm going to hang on to it. And I think that what we've shown with the Women's Health Hub pilots has been really, really promising. And if we can find ways to scale them up, and I would argue that a neighbourhood health hub is everything that the women's health hubs have tried to facilitate and to prioritise. And so it's understanding about wrapping services around the user rather than making you, Alex, as the user, have to go around all the different services. And it's not difficult to do if you just put yourself in the position of that woman, and how frightening it may be if she hasn't been very well educated or she knows nothing about the healthcare system, and how does she navigate all that? And I think that the concept of the health hubs has been a really important shift, and I'd argue that the three shifts now in this government's manifesto, the 10-year plan, is everything that the Women's Health Strategy has been trying to achieve. So, from analogue to digital, and from prevention to, from disease to prevention, and from hospital to community. That's what the strategy is all about. And as I've spent time talking to many other healthcare professionals and non-healthcare professionals about the Women's Health Strategy in different specialties, what I'm very struck by is that the MSK people, the osteoporosis and the cardiovascular people and the neurologists, just about everybody says, oh, well, we'd really like to do that in our specialty too. So I think if we can keep pushing towards this neighbourhood delivery, then we are all going to make progress, and not just in my field and Sue's field, but in a lot of other fields in medicine as well.
Thank you. Sue, you are the first ever NHS National Clinical Director for Women's Health. Can you talk a little bit about the benefits that the role has brought to girls and young women's menstrual and gynecological health?
Yeah, so I think it's been a really, really big step forward, and some of the stuff I can talk about is what seems quite sort of back office stuff, but actually I think has made a significant difference. So I think it's raised the profile. A lot of what Lesley and I say will overlap, obviously, but I think it's raised the profile of the issues for women across the whole life course, end-to-end pathways, away from gynecology, away from disease, and away from solely maternity, all really important issues, but actually broadening that out and saying, actually, we need leadership to drive forward that whole continuity of care for women from cradle to grave, but also across primary care, community and secondary care and specialist care. So I think it's created the kind of engine room and the energy around that, and not to take full responsibility for that, but having the role has enabled then to thread that idea of women's health through all the different aspects of the NHS and say, when you're looking at, give you an example, community diagnostic centres, don't forget women's health, how does this work for women? Or electives, gynecology, we need to think about that. So really being present at every door. Inequalities, obviously, inequalities for women, think about that, think about the intersectionalities. So I think creating that kind of engine room and then driving change and working with the system. This is all quite sort of boring stuff in what you see on the ground, but actually it does make a difference, because then we work with people on the ground and set a framework for how to deliver care better and reach people better. And so that's the kind of hidden stuff. And then, of course, there are some impacts that you'll see, in the media. You'll see the new NHS Online, which has got women's health pathways as some of the key pathways there. You'll see, menopause in NHS health check. So you'll see it's sort of spattered through a whole lot of things. And I think that's new, or I like to think that's new. And that's partly a sort of big collaboration across Department of Health and NHS England. So I feel that it has made a difference having that sort of figurehead there.
Thank you.
Thank you, Alex. Kevin.
Thank you, Chair. And I just need to draw attention to my register of interest, because I did work at NHS England. I think we briefly overlapped, Sue, but we never worked together, unfortunately. And I just want to ask a few questions about the relationship and sexual health education curriculum. Actually, Lesley, for you really, what is the government doing to make sure this new RSHE curriculum is delivered effectively in schools? And actually, for you, what does effectively look like?
Well, effective means, to me, looks like that every girl, we can come back to the boys later, every girl understands exactly what is a normal period, that she has the tools and the knowledge to understand when she becomes of reproductive age, which is quite young now in the Western world, that she has the capability to control if and when and with whom and how many times she becomes pregnant. And I think that those are the key issues, and that if she embarks on a sexual relationship, that she understands how to prevent being traumatized, then she prevent getting an infection or some other problem. And that if we embed those understandings in girls and in boys during their school-age years, then all of the rest of women's health across the life course falls into place. We wouldn't have women becoming menopausal, possibly prematurely, and wondering what the hell's happened to them. I mean, I still see women who just didn't know that their eggs were going to run out. And that's because they didn't know about the life course and the fact that when you start to menstruate, it usually means that you started to ovulate and you started to use up that egg reserve. So I think it's really about getting that knowledge. And your question to me was, what are we doing about it? Well, I chaired the Department for Education's review it was a quick task and finish group a couple of years ago, into the age appropriateness of sex education. And I think it certainly opened my eyes to lots of the barriers that there have been. And I think there's been a lot of misconceptions, pardon the pun, regarding what is needed and the age groups at which girls and boys need to know about these things. And if I marry that up with the charity I chair, Wellbeing of Women, we've done quite a lot of work in schools to promote period workshops. And the recipe we found most effective has been to get 10 and 11-year-olds, a group of them, and then 17 and 18-year-olds together in the same room, run the workshop. And so this is, like anything you want to ask, no questions are barred, lots of very frank answers, and then inviting the boys in to the myth-busting session at the end. And sometimes in the past what's happened is that the headmistress has said, we don't have boys. And so the response from Wellbeing Women is, well, if you don't bring the boys along to the session at the end, then we ain't coming. And it's always the young men that say, wow, this is so useful because I now know what I can do to support my sister or my mum or whatever. And there's always a little girl that tells me the same story about how she wants to tell me at the end of it, quietly in the corner, about how her best friend, and once you've heard this 4 or 5 times, you realise, this is figurative. She wants to tell me about her best friend who woke up one day really recently and thought that she died and gone to hell because she was in a lot of pain, and when she looked down, there was blood all over the bed. And I just think we can't live in a society where 10 and 11-year-olds have that sort of fear. We've got to get some ways to it. I really learned from that thing that all the concerns that there were about safeguarding and not, if you like, introducing sexual concepts to young people because that might encourage them to go and explore it. I came back completely the other way to ignorant children are very, very are vulnerable. They're not safe. And when you talk to paediatricians and also psychiatrists who are doing safeguarding and sexual abuse work, what they will tell you is that the young women, young girls who have been worst affected don't actually know what's happening to them until they have, they either go to see someone for treatment or they go to their school lesson. And it's usually the treatment. So I don't think any society can tolerate that once you've realised what the problem is.
Would that change how you frame this from the outset? If you were doing it again, what would you change?
Well, it's now been published. It was published, I think, in July, wasn't it? The Department for Education have employed Oak Academies to help them with materials to teach. To give teachers the tools that they need to give comprehensive advice and to run comprehensive lessons. I haven't seen a recent iteration. I saw them again about November time, but they were really coming on, and they were very much focusing on infographics and animations as opposed to just boring pieces of A4. So that was important, I think, and it was also focusing on group discussions and how to get young people to talk about what their experiences were, and also, most importantly, to develop a mutual respect for each other and members of the opposite sex if they are in a single-sex school.
On all that, what concerns have you got left now about implementation?
Well, my personal concern is something that I think we need to incentivise the teaching profession, and I'm not a teacher, I know, but I think we need to incentivise in some way, and I don't mean financially, but incentivise teachers to think that this is a really important part of their career and their portfolio, and possibly, I mean, we could find some way of rewarding them with certification and understanding that this is going to make them an even more employable individual. I mean, you know, there may be teachers out there listening to this today thinking, well, I don't want to do that. But if you do it that way round, as opposed to impose that task on perhaps the person who wasn't in the staff room at the time that the decision was made, which a lot of teachers have told me have happened to them, then we could actually, we will be training a cohort of future teachers who really want to do it, believe in it, and then they are respected amongst their peers as well.
That's really helpful, actually. Sue, I mean, should it be left to teachers, in your opinion, to tailor what they say and tailor their menstrual health education in particular to their intake? Particularly thinking about minority, racial and ethnic groups, or do teachers actually need some guidance on this? Do they need some external guidance?
I mean, you know, I think teachers are going to need support, aren't they, in delivering this, because we know people are people, and, you know, people have a variable amount of knowledge, don't they, and they have different populations of children that they're dealing with, so they're definitely going to need some help with that and some support. So I think the guidance is great, and it's a good first step, and really welcome it, and thinking, you know, I mean, I think the really important things about it are that young children are going to be able to understand their bodies, name their body parts, which I think is really, really key. And then as they get older, they're going to be able to start understanding their menstrual cycle, their reproductive cycle, but also spot when things go wrong. Because I know in the NHS, you know, we see some of those young girls when they're missing school, when that's become a problem. And if we have the continuity, then, you know, we start from the beginning. This is the place to start, isn't it? But I absolutely agree. There's a diversity of need, you know, and I think different children will have different experiences at home. So part of that is supporting the parents to support the children, but also they might have different sort of cultural environments. So we have to make sure it's tailored to something that's appropriate, but also that make sure that everybody has some equity of information, you know, democratising information well, I think is really, really important. So I have no doubt teachers will need some support with that, or many of them, yeah.
And across a population where there's a variation in prevalence in different ethnic groups, you know, for instance, for Black and South Asian women, there's more PCOS and higher levels of endometriosis. I mean, do you think schools need support to identify what the needs might be for their cohort of pupils at school and then tailor information to that?
So I think it's really important that we talk symptoms. And I think for young people and people who come to their doctors and come to the NHS and come to nurses, come with symptoms. They come with pain, they come with heavy bleeding that they don't manage. And I think to sort of step forward and start talking about conditions, because as long as people know what's normal or where to get help if they can't manage, and when to go, and the fact that if they are having 3 days off or more off school every month, that's not, you know, that's not an acceptable thing to do. So go and get help. And then hopefully the system is good enough then to start teasing out whether these are normal bad periods or whether there's sort of an underlying condition. And to be honest with you, things like endometriosis and fibroids, they develop over time. So actually, if young people have that understanding and they know when to get help, then we'll minimise that development of those conditions much later on. So it really does start here, and getting it right is here. But I think it's not so much the conditions, I think it's the symptoms, what they're experiencing, what they should put up with, not tolerate.
Thank you, Kevin. On that, do you find, either of you, that girls are listened to when they are coming in with those first kind of signs of potentially developing something like endometriosis? Do you find that they are listened to?
I do. So I think we know generally, don't we, that there is still, and when we think about some of the challenges that are still there, we know people are still telling us that they don't feel listened to. And there are really good pockets where people do feel listened to and some experiences where they don't. And we really do have to get on top of that. I think for girls it's very, very difficult because they're often being told their periods are normal. And when they're really absolutely not. And so I think, you know, there's the two sides of it, isn't there? Empowering the girls themselves and their parents to say, actually, you need some help here. And then really getting to the healthcare professionals who see them, the school nurses, to just make sure that they're taken seriously and there's a route of access for them to go, okay, I can't manage this. This is the next place that you go to. What we're trying to do actually is we're going to be introducing a sort of skills framework for lots of areas of women's health, but really sort of what is the basic knowledge that people should have, including how to think about providing compassionate care, culturally competent care, and then what's the next step and what is the next level of skill, so that you can start thinking about this stepped level of skill mix in a community so that every person should be able to work their way through rather than either getting nothing or going to secondary care gynecology. So I think it's really trying to, and obviously general practice is the absolute central point of that and should continue to be so and provides very good care, but just a bit of extra support for that.
And I think we have heard anecdotally and also from some of the witnesses that young girls that are expressing issues with their menstrual health very early on quite often just get offered contraception. The answer is just to stop the bleeding. Is some of that framework going to tackle that issue rather than just stopping the symptoms, finding out the causes of these symptoms instead? Are we moving towards that?
Very much so, but I think it comes back to Sue's point, which I really echo, and that is it's symptom-based as opposed to condition-based, because you don't wake up with endometriosis one morning, and nor do you wake up with, terrible menorrhagia because of your fibroids. They do develop over time, and there's a lot that can be done if they're not allowed to basically deteriorate. So the reason why we have these problems at the moment, and we have very, very distressed and angry women, and I get why they're angry, is that they have been ignored, and whilst they're waiting for help, their problem is progressing. And there are lots of different ways now in which one can alleviate that. So, for example, you've heard of the Mirena devices. I think one of our next programs is going to be all, campaigns needs to be, please don't believe what everybody in your family, your mum and your grandma and your auntie told you about coils. The new coils with the progesterone hormone in them, actually they cure those problems that the old-fashioned copper ones used to cause, eye pain and heavy bleeding. And that's exactly why we use the Mirena ones, and there are lots of different strengths and types, Kylenas and all sorts of other ones, JDS. So we've really got to get them to understand that these are ways of controlling it. One of the things I often say to young women, or girls between the ages of 12 and 18, if they've come to see me, is that you've got to remember that your womb lining's got no brain of its own. All it does is respond to the hormones it's shown. So what we're going to do with this is put something into the womb cavity that's going to stop the womb lining from building up. And it's not going to work this week, and it may be a bit crampy for a couple of weeks while it gets settled in, but after a couple of months you're going to notice that the bleeding is much, much less, and the pain is so much better because the womb lining is no longer able to build up. But most importantly, I think we have to emphasise to them as well, and probably their mother who's sitting trying not to interject throughout this, that the moment that you remove that coil, that Mirena device, that her fertility will come back immediately. So there's no post-pill amenorrhea or missed periods or anything like that. It comes back straight away because all you're doing is putting something mechanical there to stop the womb lining regenerating, if you like.
And that they can ask for pain relief.
And that they can ask for pain relief. Yeah.
Brutal.
No, and there's absolutely, it's not acceptable at all.
No, and if men were having something similar, I'm very sure that they would be offered pain relief.
That's often a comment I make as well.
Yes. So coming on to the kind of symptoms and the symptom checker and the period checkers, the well-being of women's period symptom checker, will the NHS add a link to that in the women's health area of its website, do you know? And if so, when?
Yes, that's for me. So the period symptom checker is a brilliant tool. I don't know if you've seen it. Very kind of, very for it. I would be really keen to see it used really, really well. You probably know that the processes in order to get things on the NHS website are, for good reasons, I think, very rigorous, and they require quite a lot of scrutiny and processes. And those sort of checks and balances are in for a really good reason, so that... But obviously for this it's much more difficult, isn't it? Because that means that it's been very difficult to sort of think about just going forward and hosting it. I think that probably we were looking more carefully to the idea of it being a signposted thing, and I definitely have that on my list of things that I am doing actively.
I'm going to push a bit more on this, because I think all the while that there is a delay in putting a reputable period symptom tracker up there, young girls and women are finding different apps, different social media tools, for which they are garnering huge amounts of data about our health, about our children's health, and not always, shall we say, the most evidenced research and guidance. And sometimes guidance that has been agreed by a different country that is not our own. When we delay this, we're actually blocking and creating a barrier to really decent information for young people. Is there any time frame which we can see this to come up, even if it is just signposted on the NHS website, where parents and children will know this is something that I can use, that the data won't be abused, isn't necessarily sold off to another company, and will give me NHS approved guidance in the way that we all trust?
I think we need you to help us influence that.
Yes. I'm just trying to find out from the NHS where we can see some process. Like, is it going to be within a year? Because I understand that you want to have stringent and robust policies in place, that you would never want anything that the NHS would never approve of on its website. But this does seem like a really obvious tool that is going to help young people. And all the while that it's not there, they're going to go to less reputable sites.
Can I agree to come back to you on that and take that away?
Okay, thank you very much. I really appreciate that. Now, I think, Sue, you mentioned about naming of body parts. We had a fantastic session here.
Oh, I watched it.
Did you? Did you ever think we'd kick off a select committee with the words clitoris, vulva and vagina?
So much fun.
Wasn't it? It was so much fun. And then we ended up with a song with it. Never thought we would ever see that in this kind of slightly stuffy environment, frankly. But like that stigma, we really need to break down. Dame Lesley, social media platforms, and we were told during that session, but we all know it, are repeatedly banning content about reproductive health, even from really reputable influencers, GPs like Dr. Nigat Arif and Dr. Aziza Cisse, for being inappropriate. And Aziza was also told like she couldn't come in with those words written on her. Yes. They're not rude words.
No. They're great T-shirts too, aren't
great they? T-shirts. I've got mine. I can't wait to wear mine out to Sainsbury's. But, you know, they're being told that they're inappropriate, but this creates an added stigma. So what's being done to tackle this problem at the moment?
Well, you held a round table very recently, I think in November, or perhaps it was the beginning of December, on shadow banning, which was very well attended. And there were a lot of individuals representing, when I say industry, but organisations or companies that have been affected by this shadow banning. And I didn't really understand the word, that, because it doesn't sort of explain to you exactly what it means, does it? But, and one of my suggestions was perhaps you need to change the words because it could be immediately obvious. But there is going to need to be a real shake-up, I think, in the way that companies are allowed to fiddle around with the algorithms to get themselves farther up the chain. Now, that's beyond my technical skills to get myself up the Google, whatever it is. But if I talk to my daughters about it, one of whom's a graphic designer, she tells me it's actually, there's just a well-rehearsed way of going about this. So I think we've also got to, if we want to make if we're not going to change, we're not going to change the way the young generation are going to access their information. I think we have to join them in those places and make sure that it's full of really good evidence-based, factual, correctly used terminology. So we can't beat it, so we have to, I'm not saying just join it, we've got to champion it, I think. So, as you know, both Aziza and Nigat spend a lot of time each month producing TikTok videos. And
they're brilliant.
And they are brilliant, yeah. The great thing about Nigat is that she's got 3 boys and they edit them they edit their mum's videos and put them up online.
That's brilliant. And she did talk about some of the abuse as well that she gets, and I think Aziza as well. And I think as 2 women of colour talking about women's menstrual health, I think they also suffer from an additional pressure that isn't just from the algorithm, but it's societal as well. I think that you talked about powerfully about the power of social media for good there, and I think those 2 women are a fantastic example of it. But we are also in a conversation at the moment about banning social media for under 16s. Have you any thoughts or analysis about the potential damages or the potential benefits of this on young women and girls' menstrual health?
Well, if we ban social media for under 16s, we're going to have to find additional ways, or alternative ways, I should say, of communicating what they need to know. So we will have to pursue that. I still think it's going to be quite difficult to police this ban. But I think there will always be the need for really high-quality, evidence-based information that is straightforward, that it's available in lots of different languages, and also that we don't just talk about printed words or just spoken words, that we actually do have animations. I don't know about you, but Sarah, but when I see an infographic, I immediately remember it. As opposed to if I read a paragraph, I might not remember what the percentages are. But the infographics are very, very powerful, and I think we need to use all of those things too. So we're going to have to, I think there's all sorts of things. I think we need to also recruit quite a lot of more, in quotes, celebrities to be telling girls about the right things.
And engaging people. I think there are still medical professionals that are incredibly engaging. They may not be celebrities, but they speak about it in a passionate and informed way, in a trusted way, but a way that's totally accessible. And we'd also heard from deaf people and deaf organisations and charities where actually I think not just different languages, but also BSL being appropriate as well. And it's something that Aziza said, that there is a real delay and too many hoops to jump through, is the quote that she used, around multilingual videos for the NHS about whether it's screening, whether it's menstrual health in general. We have a real barrier here. And also some of the language, we talked about this earlier in our private session, even things like FGM. We use that phrase, but different cultures and different societies wouldn't use that phrase and wouldn't use that description of female genital mutilation. They use something completely different. Is there anything that the NHS is doing to improve the accessibility of the information, whether it is through using influencers and celebrities or people from the medical profession that speak, for want of a better word, in a slightly more normal, accessible language, and also people that speak in a culturally competent way as well?
Yeah, I mean, I think that there's a lot to that, isn't there? And I think that on the one hand, it's the media that are being used. On the another hand, it's the content, and then it's about the accessibility of the information that's being provided. In terms of the media that are being used, I mean, the NHS is using social media, so there are, and you've probably seen some of them that uses YouTube and Facebook and Instagram, maybe in a less kind of dynamic way than a Caesar and Nigat, but certainly we do pull on those, and there's some quite good endometriosis kind of YouTube videos. There's some things around menstrual health, so that there are some sort of nice, I think, that there's some good content. I think that obviously we try and stick to the accessible information standard, so thinking about the reading age, really, really important. I think, the written content is obviously quite kind of, has been called kind of bland, but it's very good, informative stuff. I think that one of the things about being sort of culturally competent is I think we really need to think about sort of having, there's some generic information, isn't there? And then there's some sort of, there are so many different communities that we absolutely need to be mindful of. And really it's about sort of supporting the local systems to identify their particular populations and then help them to translate the information into different languages, the local languages, or making it more accessible for particular populations.
Is there a strategy to prioritise ethnicity groups, for example, that we know that are prone to, for example, endometriosis or PCOS or ovarian cysts, such as many black women are much more prone to these conditions? Is there a strategy within the NHS that looks at prioritising accessibility of information to these groups on issues that we know impact them more?
Yeah, so we've just developed an equity framework which focuses particularly on two conditions, and one of those is heavy menstrual bleeding, where we know that there are real inequities, and the other one is menopause. So that's the sort of starting point. And what it does is it lays out a really, really comprehensive set of sort of support tools for the system, including how to think about your communities, how to make the information accessible, what's already available, what can be translated and modified for that local system. Because from a sort of national point of view, we're constantly thinking, how can we do something useful that then can be localised? Because we can't provide for every detailed bit.
Oh no, absolutely. I think we completely understand the pressures that the NHS is under, which is why I'm asking, is there a strategy to prioritise in the areas that we know that there are communities that are going to be more likely to suffer from certain menstrual conditions than others? And also is that the two that you mentioned are very much targeted at women, and one section older women in general. Anything in terms of girls?
So nothing like that specifically around girls, but certainly heavy menstrual bleeding. Well, heavy menstrual bleeding transcends, but it's specific to heavy menstrual bleeding in this tranche. But it can be eventually, there are a number of conditions on there. So we've focused on those two specifically at this point. But certainly we kind of review the needs for information in other areas.
Thank you. Thank you very much. I'm going to hand over to Christine, but I'm just looking at the minister's on his feet, so I'm worried that we might have votes. But if we are interrupted, we will vote and come back as quickly as possible. Christine.
Thank you. I wonder if we can ask you, first of all, the 2022 Women's Health Strategy emphasised the potential benefits to girls and women of femtech apps. Do we need actions in the renewed strategy to manage better the risks that can come with them? And if so, what do you think that action could look like?
So I think, obviously there's an explosion of apps, and there's some really, really good ones, and it's really moved things along, I think, for women getting information. And I think that we can broadly sort of think about apps in terms of more well-being type apps, and then the more kind of medical device apps. So when we start thinking about risk in terms of clinical risk, we need to be sort of thoughtful about actually what kind of information is being provided, and is that something? And so we're starting to, so you probably saw in the 10-year plan that there is going to be a link on the NHS app to sort of apps that are kind of checked and sort of verified so that people can find their way into useful information. I think one of the things, we are very wary that people are also getting misinformation. And I know that you kind of, one of the conversations that came up earlier actually was about things like hormones. So I think that there's a lot of, it's a good example of where apps are giving people very confusing information about what is helpful and what isn't helpful. So part of it is to kind of think about how you can regulate the apps, but part of it is also thinking about how do we have better conversations with people so that we can take on board the information that they've received through apps and make sure that we have to shared decision making, takes account of their information, but also helps them to understand that in the context of what is good information and what's misinformation.
So, would that be how you see the NHS as sort of directing women and girls in the right towards the correct apps, and that would be their role? Would be very much, or part of their role would be very much to do that.
I don't think that the NHS will ever keep pace with all the apps that are, coming up. And obviously it's a really, really huge and dynamic sector. But I think the NHS can and does look at, so we've got a whole team sort of looking at innovative things that are coming through and looking at getting them sort of early value assessments, getting them as, whether they are registered as what's called medical devices, whether they're things that are good legitimate information. But keeping pace with all those apps is an ask, I think.
Yeah.
Lesley wanted to come in on
I
that.
just wanted to say as well that I think we do need to think very much about how we partner with industry and with pharma and with charities and VCSE in general, because there's an enormous amount of good work going on, which we've had a tendency, both our organisations, to say, oh no, we don't do that. And, my famous comment about we need an open door, or we need a door that's recognisable that you can go to and then bring your idea and be guided through a pathway, which doesn't mean that you get special treatment, or you don't go through the governance and the probity and whatever, but that you're guided rather than having to find your way. Because a lot of these organisations and charities and things, they just give up because it just becomes too difficult. And I don't think we can afford to do that anymore. I think we really do have to welcome their expertise. I mean, the number of charities, for example, or self-help groups that will invest hard-earned money into getting another information sheet about something that there's masses of really good information sheets about. It's just nonsensical. So I think we've really got to find a robust and an honest way of partnering with a lot of other sectors to improve healthcare for girls and boys, and women and men.
Would you say it's an aim to make femtech functionality, such as tracking menstrual well-being, available via the NHS app?
Sorry, could you repeat the question?
Yeah, is there an aim to make femtech functionality, such as tracking menstrual well-being, available through or via the NHS app?
Yes, there is. So the ambition is to have on the NHS app access to verified and kind of recognised sort of different across all the sort of spectrum of healthcare, including femtech apps. So that's absolutely an ambition. So yeah.
Okay. We've heard from a range of witnesses who've emphasised the risks of femtech based predominantly on data from white middle-class users, entrenching health inequalities for more disadvantaged groups. How do you think that should be addressed?
I mean, I think we do have to be very mindful, don't we, that, and it's true across the sector, it's true in AI, it's true in research, it's true that, lots of the data that we use and that gets plugged in comes out based on not a representative set of data. So I think that we need to continue being critical about how we look at data, understand which populations are being missed, and always be mindful of actually that we're looking at it through a very particular lens. And I also think we need to strive continually to try and make sure that we get representation from those groups that aren't, so that we start getting the data that goes in being much better and much more recognised. And I think there's all sorts of ways to be doing that, but working closely with the communities themselves, understanding more about what their needs are, but also how they themselves, they want to be engaged with research and those kinds of data collection. So I think coming at it at the two ends, remain critical, but actually let's try and change that that sort of kinds of information that we're seeing.
Thank you.
Then Lesley, did you want to add anything before we go to...
No, you go and vote.
Thank you. I'm just going to suspend the sitting for this vote, and then we'll be back as soon as we can.
Very quickly.
Welcome back to the Women and Equality Select Committee. We'll be resuming the session following vote, and I will be handing on straight to Nia for research.
Well, thank you very much indeed for coming in, and obviously I think there's been a considerable concern about the proportions of research that are devoted to various different things, and what I really wanted to ask is, has there been any progress in increasing the volume of research into women's reproductive health?
Yes, I think there has been an improvement. It started from a very low baseline, though. I think it's 1% of research spend goes into specific women's health, and I think that the strategy, together with all the work that consultancies like McKinsey have done to try and demystify or myth bust some of the things that were considered about or wrongly thought about women, has helped organisations that are involved in research and the funding behind that to think rather differently about it. So, for example, the NIHR, which of course is something that is obviously in the department, is no longer able to assess grants, let alone grant them for research, if it doesn't include women, and also women of reproductive age, if that's relevant. Because in the past, women of reproductive age were often excluded, particularly if it was an intervention trial, because they were worried about an unknown pregnancy or a known pregnancy. And also women were, and this is what I find so extraordinary, women were thought to be too complicated. And so I've often had pharma and industry telling me, oh, no, it's a niche market. To which my response has been recently, well, what can be niche about 51% of the population? But that's what has been said. So in fact, the sort of the work on, if you like, purely reproductive stuff only accounts for a very small percentage of the problems in women's health. And then there's a much larger group which are issues that really disproportionately affect women. So things like thyroid disease and rheumatoid arthritis, migraine, premenstrual tension and PMDD disorders. They are women. And then there's a large group as well where women appear to be disproportionately missing opportunities for treatment. And so that's, there are data to show that a male presenting with palpitations and a heart arrhythmia is 3 times more likely to get resynchronized electrically than a woman. And that's opened understanding in the fact that women's cardiovascular symptoms present very differently. And it's been assumed until relatively recently, I'm talking about the last 3 to 5 years, that everybody presented the same way. And if you had crushing central chest pain and a pain that radiated down your left arm, that was a possible heart attack. But women tend not to have that. They tend to have indigestion or pain in their back or feel just terribly worn out. That's cardiovascular disease, which I've mentioned specifically because it is a problem that affects women disproportionately, and also because their symptoms are different, they have been neglected, and therefore they tend to get their diagnosis later when their heart disease is more advanced, and then we find that the treatment has been trialled in men. And women do respond differently. So there's the classic thing about troponin levels, which is the chemical you measure in the blood sample if you go into casualty today with pain in your chest. And it's now been understood that troponin levels are much lower in women than they are in men. So women used to be sent away saying, oh, you haven't got a heart attack because it's the thresholds here. So I think there's a much better understanding of that. And I'm going on about heart disease because that is the major killer in this country.
I understand, Chair, it's a slight deviation from our topic, but on that, is there any concerted effort then to ensure a much more balanced cross-section of the population in the trials?
Very much so. So that's what I think is changing. I mean, that takes time because there's a throughput, isn't there, when you set up a research study and then you perform a trial and then you introduce an intervention. So there's a pipeline that has to be gone through. So it's not going to happen overnight, but it is certainly moving.
Right.
And I think there are many of the major funders now, so NIHR, Wellcome, MRC, they're not going to fund something if it relates to women as well, if women aren't proportionately, i.e. 51%, in the trial cohort.
Right. So in terms of the particular study of this inquiry, what are the gaps that you see remaining in relation to menstrual and gynecological health research?
Well, I think it's not so much the gaps, but we've got to now implement what's known about it. And I think it comes back to Sue's point, which she put well earlier, and that it's a lot of the time the gaps are thought to be, as someone would say to me, well, we must do something about endometriosis. No, we don't need to do something about endometriosis so much as make sure that girls and women understand about what a painful, heavy period is, what is acceptable, or what is normal and what isn't, so that we've actually got the focus on the right things that will change it, and getting health professionals to understand that as well.
So in other words, if you were renewing the women's health strategy, you would be focusing on learning from what we have found out and
Absolutely.
implementing it more universally as opposed to perhaps patchily as it may be at
Yes.
present.
And so, for example, in the big killers of women that I was talking about at the beginning, that heart disease predominantly, and then osteoporosis and MSK problems and frailty and then dementia, all of those groups working in the major condition strategy are recognising that they've got to look at women's studies and women's interventions in a different way, and they've got to be seen as a different group.
It's very helpful. Sorry,
Can I add something to that? Because I think also the other thing to think about research, there's always the sort of traditional researchers and the big studies, but the world has changed, hasn't it? And the pace of innovation is so rapid. And I think really responding to new innovations, particularly in this world, is really important. And I think what we're trying to do really is to think about what are the new innovations that are out there, how can we support these kind of early things with early promise. So there's some things like early diagnosis of endometriosis, for example, with blood tests and things like that. So supporting with small grants to develop those innovations, and then a sort of accelerator program to try with things that show promise to try and get them accelerated through the system so that they can actually be used. So a good example of that is there's a new test coming out that can diagnose endometrial cancer through just a swab. So that seems like a very important thing. And when we think about pain, maybe later on, actually preventing people having hysteroscopies is going to be really important. So, and then working with the system. So we've got something called the Health Innovation Networks, who work on the ground and say, this is something that's in need. What have we got in terms of innovation? What do we know is good and works and robust? And then how can we adopt it and then scale it up more broadly? So trying to think about that whole pipeline, just rather than doing that very sort of, the slow, long studies are really important to answer the big questions. And there are quite a few of them in train at the moment as well. So I think it's the two sides. So
you'd be saying focus on some of the very practical things which will actually make diagnosis much quicker, hopefully, and more accurate.
Yeah, so I guess it's the particular areas really in diagnostics, you're right. That's the sort of commonest place where there's that kind of innovation which will make a difference to people, actually, if we can get them out there.
The other thing that needs to be really focused on, I think, is training the next cadre of researchers, because you can have all the money in the world and all the clever ideas, but if you haven't got people trained to undertake research, then it's not going to go anywhere. So I think that's really important. So charities particularly, and funding organisations that provide training fellowships or start-up grants to collect some data, which then makes you much better able to apply for a bigger study, are really important to prioritise.
Thank you. The bell has gone again for third reading division, and I think we will, once we come back, we'll be able to finish the session properly. Until then, I suspend the sitting. Welcome back to the Women and Equalities Select Committee again. I'm told that there are no further votes until much, much later now. So I'm going to hand over to David.
Thank you very much, and lovely to see you both again here, so thank you for coming in again. I'm going to talk about pain, unfortunately. So why is the message not getting across to all healthcare professionals that severe pain is not normal or acceptable in relation to procedures such as laparoscopies, put my teeth back in, or coil fittings? Maybe to you, Sue, firstly.
So I think that there are pockets of good practice. So I think that for some, and there are some procedures that women do tolerate reasonably okay, but I think that there is an unacceptable, you're absolutely right, there's unacceptable levels of pain still being experienced, and we are making a really strong commitment to kind of tackling that because it is really, really important. I think we spent quite a lot of time talking to, so there's been a bit of a gestation here because we spent quite a lot of time talking to people, talking to Tiger, talking to the campaign against painful hysteroscopy. We've looked at some evidence about, how to improve pain. We've been speaking to stakeholders, so really trying to get a sense of what the whole problem is, and it's obviously right through the system. It's really making sure that women are adequately informed before they even start to go forward for a procedure. So there's some good standardized information, making sure that every single person gets that information and also has a conversation to think about what are their options, what will they expect. So coming a little bit more prepared. We've heard that loud and clear. Really, really important to make sure that that information gets to everybody and that people have clear choices about what kind of procedure they have in what setting and with what pain relief. So we're very clear that that's what's needed at that end of the system. And then around the training of healthcare professionals and for people to really, communication is so key here. And when we think about the skills framework that I talked about, that kind of trauma-informed care that we're developing and will publish. So trauma-informed care, good communication, culturally competent and compassionate, will be really, really, throughout all women's health services, really, really key. Then we're looking at different new pain relief options, what can actually be delivered in different settings. And then systems of how actually are the systems sort of structured to enable people not to experience so much pain. So what's available in what settings, and you'll realise that there are some new centres like community diagnostic centres, for example, if people are having hysteroscopies off-site, what's available, those kinds of things. And then lastly, and really, really importantly, to try and make sure that we record people's experiences in a way that they don't feel pressured to report good experiences. So really trying to think very carefully about what proms we're going to use to ensure that actually the services then can look at what they're doing and look at where the improvements are needed. So all that, is a big bit of work, and we're committed to making a difference with that, certainly. And you'll have seen in the 10-year plan about the sort of commitment to patient experience and, how we can help incentivise the system in order to help women get better experiences. So it is actually something I do feel quite passionate about. So you can rest assured that it's in train. And I absolutely agree with you. It's not okay.
That's really helpful. Perhaps just moving to you, Dame Lesley. Are there any particular reasons why women are still being made to endure significant pain, do you think, despite clear guidance against it? For example, are there workplace pressures? Is it simple medical misogyny? And do we need greater accountability for healthcare professionals conducting extremely painful procedures in contradiction to the guidance?
Well, I think there's always going to be the importance of accountability. And I'm not going to use all those very emotive words because I don't think that actually moves us on, but I do think that it's very important that the strategy refresh, which we're working on at the moment, emphasises how important girls' and women's experiences are and how it is not acceptable not listen to them, and it is not acceptable to presume that somebody from a different ethnic group to myself has a higher pain tolerance, or because she's delivered 2 children vaginally that she doesn't, in quotes, deserve or isn't going to need any form of pain relief. I mean, I think a really good example is young girls who are coming in with painful or very heavy periods, quite disabled, they're not able to go to school. I mean, if you were to do a speculum examination in an outpatient clinic, you're probably going to traumatise them if they're under the age of 16. And so often what my challenge is persuading the person who's with them, the family member or the guardian or whatever, that actually what they need to do is to come in for a very quick day case procedure somewhere where they're going to have no memory of what that is going on. And you don't even need a general anaesthetic. You can now provide deep sedation in a relatively low-tech day surgery unit that they'll have no recollection of it. Because if I did that to a 15 or a 14-year-old, they're never going to go to a gynaecologist again, are they? And they're the group that will never have a smear again. They won't, they'll be frightened of all sorts of things. So I think it's really important that it starts very early and then it continues, that nobody needs or should have pain, and that we must ensure that we provide for it.
Okay, thank you. Sue, coming back to you, what was discussed and what actions were taken forward as a result of the NHS England stakeholder meeting on women's chronic and procedural pain held last November, and when are we likely to see any progress?
So you'll be aware that there was a number of stakeholder panels that were convened as part of the strategy refresh, and the roundtable on pain was actually as part of that kind of group. So it combined the intention to do that anyway with this plan. So I think that it will be a commitment in the strategy. And obviously implementing things takes time, but rest assured that we will be reporting back on what actions we've taken. You know, this is very much a live issue. I can't give you an absolute date on it, but it is underway as we speak.
Okay. Do you know when we would expect to be able to be given an exact date? Do you know the time frame for almost putting the time frame in place?
Yes. An exact date of making a change or what's actually going to happen? Sorry.
What's actually going to happen?
Yes. So I think there will be some things that will come through in the strategy that we will then supplement with a follow-up, some reporting about what else we're going to do.
Okay. Thank you. And Dame Lesley, you touched briefly in your last response on some of the experiences of black women, and I've met with some myself who have given me horrendous stories of the way they've been treated in terms of their expected level of pain tolerance during certain procedures, especially women-specific procedures. So how prevalent do you think amongst healthcare professionals are these discriminatory attitudes towards black women's tolerance of pain, and what steps are being taken to address it?
Well, even if there was only 1 or 2 examples that I'm aware of, it's not acceptable, is it? One case is far too many. But the accountability issue, I think, is really important, and Sue's comment about collecting data about experience that in a non-pressurised way, so that somebody has to feel that they've got to say, oh, it was fine. There are sophisticated ways to do that and collect that data. But most importantly, I suppose the thing that I often say to trainees when I'm teaching them, or they're with me and they're learning, is, well, what you need to think about is how would you like your sister or your daughter or your mum looked after? And that may sound a very simplistic thing, but it's really quite important, isn't it? You know, you've got to think about how you want somebody you really care about looked after, and would you want them to be experiencing what is obviously a painful procedure?
I mean, look, the fact that there's pressure groups set up to I guess lobby on this issue, and
yes.
Had groups come and meet with me, says that this is quite a big problem, I guess.
It is, and I think there are a lot of contributory factors, and we are the NHS is strapped for cash, so and it's also strapped for time. So if, for example, Sue was to come and see me, or say one of my daughters was to go and see Sue, a young woman in her 30s, and putting in some Instilla gel into the vagina and waiting 5 to 10 minutes takes time. Takes the 10 minutes, and then, possibly then putting in an injection into the neck of the womb, saying, I'm going to ask you to hold my hand or hold the nurse's hand or whatever whilst I put this in, and waiting another 10 minutes. It takes time and it takes resources. I mean, they're not expensive things, and that's my argument, and that's been our argument throughout. And that's why we need to have a round table on it and to keep following up on it. But it does take time. And I think there's been an enormous amount of, and I'm not against that, but I'm just saying we have to factor that in, but say it's just not acceptable, and that's why the community space is going to be so much more helpful, and be able to facilitate so many more girls and women getting the care they need in the way that they need it and with the right pain relief.
And I guess one final question for both of you, just relating to this whole topic of potential discrimination. Do we need some tougher actions to tackle unacceptable racist assumptions within this particular area?
We definitely do, and I think we can learn a lot from maternity, because we know that the outcomes for women of colour in maternity are so much poorer, and maternity a little bit ahead in terms of putting some things in place. But I think that the structures that are embedded in the NHS need to shift. They definitely do. I do think that trying to embed culturally competent staff within those services is really important, and we will work really hard to make sure that those staff, as a start, it doesn't solve the problem. That's the problem is much bigger than that. But I think that's a really, really good first step. And certainly we will be ensuring that that's a marker of a good service standard.
Thank you. Lesley, do you have any further views?
Well, the team sitting behind me have heard this story so many times in the last couple of weeks, but it really impressed. I saw a woman, a relatively young woman, a black woman, who was brought in on one of my early day surgery lists early in the new year, and she had been in and out of hospital, my hospital, for the best part of 11 or 12 days, occupying a bed, and during that time she'd had 2 blood transfusions, and she had a problem that nobody had got to the bottom of. She was being transfused because she kept losing a lot of blood. I felt really upset about the fact that she'd had these 2 procedures and yet still the problem hadn't been resolved. And I must say, possibly this is my character, I went through the notes in the hospital system, and I made a note of everybody she'd seen, and I'm working my way around them all, saying, why did this happen? What was it that made you think that she didn't need pain, which is why she refused to have anything further done in casualty or in the gynae outpatient? So there were a lot of people that were inappropriately or behaving inappropriately, in my opinion. So trying to find ways to do that in an encouraging way, to say, no, we can't do that, as opposed to an accusatory way, I think is something that the leadership teams have got to deal with, and accept the fact that it's happening, and that we mustn't tolerate it at any time.
Helpful. Thank you very much.
Thank you, David. I just want to ask a follow-up question from David's questions there. Is the NHS prepared, I think, for obviously the training need that we have here? And is it robust enough to withstand the obvious criticism that we are seeing around what some political wings will call a woke culture, rather than what we actually do need as a society to be able to best provide healthcare for women from all walks of life?
Oh, I don't think there's anything woke about pain, and because pain is an experience, isn't it? So every person in this room will have a different experience of pain, and they may well have different thresholds. And when you say woke, if you're referring to gender, my view has been very simple about this throughout my practicing life, and I've been around for over 4 decades now in a gynecology clinic. And if you walk through the door, whatever you look like and whoever you say you are and whatever your name is, if you need me, I will look after you. And that's what we've got to we've got to imbue, I think, in the generations coming on and that will be replacing us.
I think that that's very welcome to hear, and obviously that is not an issue that I would ever describe as woke, but I do know that there are areas where there are political change across the country which may impact on how ICBs perhaps function, and particularly if there is a change in the mainstream thinking as to that, you know, work on EDI, for example, or actually catering and being culturally competent isn't the priority or shouldn't be the priority for something like the NHS. Do you think the NHS has had that embedded in itself enough to withstand any political pressure that may come in the future?
I think that health inequalities are really firmly embedded, and, you know, Core 20+5 is alive and well, and Core 20+5, for those of you who don't know, is a whole system of trying to improve and reduce inequalities around socioeconomic disadvantage, but also ethnicity across major health areas. And, you know, there's work alongside, for example, the electives plan about how to tackle inequalities. So it threads through absolutely everything, and it needs to be embedded. But there is a much wider issue, isn't there, about, you know, who are the leadership and people working in the NHS and society. And so it's obviously a big issue, but certainly embedded in NHS policy, yes, I would say, yes.
Thank you. I'm going to bring in Kevin and then we'll go to Nia.
Just following on from that, I mean, I think I'm very aware from working in the NHS, in NHS England, and knowing what some of the policy at the top is, and also then working in hospitals. And I know from my local hospital, which does have some really big cultural challenges about racism from to staff but also from staff, that actually there can be a disjunct between the policy stance at the NHS at a national level or regional level, or even at trust leadership level, and the cultures on the ground. What work do you think we really need to do to make sure that this isn't just Core 20+5 and all the great stuff that's doing? Yeah. It's right down to the front end, particularly when we're resource staffed in the NHS, and time is tight. So cultural change work can be, and it takes a lot of time. It's quite hard to do. So what more do you think we need to do there?
Yeah, and I think, you know, of course it's leadership from the top and from the national level and sending a signal, but a lot of this stuff is also really embedded that in our local institutions and organisations. And a good example of one initiative would be the cultural champions, for example, who are now embedded in NHS organisations to look at racism on both sides and try and manage and ease that kind of issue. But I think that, you know, these are local and national issues, but if we don't, you know, Core 20+5 isn't going to do it. It needs to be threaded through everything, but I don't think it's. I think it's for also, you know, sending a signal to say that absolutely at the core of what we do and having it in every single policy. But actually, what gets done and gets led on the ground is also really important.
Thank you, Kevin. Nia.
Thank you very much both for your previous answers, and you have already touched on training to a certain degree. Unfortunately, we've heard rather negative things, such as nurses having to fund their own training, GPs telling us they can't find the time to do the training, and trainers with burnout. So how do you think we need to go about ensuring that we get a better training right across the board in women's menstrual issues, particularly obviously, you know, GPs frontline, nurses obviously in many different contexts that they work. You know, what should we do about the situation?
So I think that on some levels the system change that is sort of going forward is going to help and support that community of practitioners who are trained and fit for purpose. So I think that, you know, starting from the primary care perspective, we've heard, haven't we, in previous witness, you know, primary care have a huge portfolio of work, and they also have very little time in their specialist training. They do get training in obs and gynae, but not all of them. And so one of the issues is always going to be variation. So I think that by ensuring that we have a population of healthcare professionals who women can move seamlessly between if skills aren't met in one setting, that it's very easy to access them in another setting. I think there's a basic level of skills that should come through the training, but we're going to be helping to map those to make sure that every single person on the front line has those skills, and then also supplement them with people working in the hubs or the neighbourhoods to ensure that, and asking the system to look at what skills they have in their system and make sure that they meet the needs of the population. So very much that kind of population approach, like these skills are needed for this group of women. Where would they find it? If I was going with very heavy bleeding and I went to a GP who that might not be their primary interest and they reached their I wanted an IUS, where would that GP easily send me straight away in order to get what I wanted or know when to refer? So those pathways are really important. We're working with an organisation called Clear, who are really good, who are at this moment trying to sort of map out those pathways and what is the workforce and what are the training needs to match that.
There are some other factors that are starting to contribute to this problem. So the GMC have recently, they are introducing their medical licensing certification, so that ensures that whatever branch of medicine you're going to go into, you're going to have some knowledge of women's health, really important, because 51% of the population, the vast majority of them are menstruating at any one time, for example. But you were talking about procedures, and so if I go back to my Mirena coil example, I mean, the problem has been that the commissioning for providing contraception and menstrual management of painful heavy periods and menopause, for which it's often a very useful tool because it protects the womb lining, the endometrium, from being activated by the estrogen part of hormone replacement therapy. All three of those are obviously all done by the same thing, and it takes exactly the same technique to put it into the uterine cavity in a painless and effective way. And yet you'll find that there will be people who have gone along for contraception and been told, oh, you can't have that done here because we only do menstrual management or we only do menopause, and vice versa. So, and by the way, while that young woman or older woman is having this procedure done, is undressed, often the clinician that she's with is not meant to do their cervical smear at the same time, because that's also commissioned in siloed pathways. So that's why we have to talk about this leadership in terms of understanding that we have to wrap services around women, and even if that being the right thing to do for women to be able to contribute and not have to go to umpteen different appointments, I think we have got to instill in those leaders the fact that we cannot afford to carry on doing this so badly, because it's costing an absolute fortune, and it's money that can't be then used to channel into the research you were asking us about earlier, and or improve services for all those things that we're going to have as older women, because we are going to live much longer than our grandmas. So I think we've got to think about it. And the comment about payments for GPs, it often comes about long-acting reversible contraception or putting implants and LARCs in and things, coils and implants in. And they will say that they can't afford the back pay to fill up their surgery while they go to weeks and weeks and weeks of training courses. But the health hubs or the neighbourhood hubs are a perfect training resource. So if you came to me and you wanted to learn how to do that, and we spent a day together when all we were doing was putting in Mirena coils or implants into arms, I mean, you'd have the experience you needed in a very short space of time. And I think we also have to make that a training program that is free for the person who's doing the training, because you can't expect people to want to go and spend their hard-earned cash, particularly if they're nursing professionals or healthcare assistants, on getting the training and then maintaining the certification for something that's meant to be improving the lot of the patients that they're looking after. So that's when I come back to the partnerships I was talking about earlier. We need to partner with, with our other organisations that's going to provide this training for them and provide them with packages so that it becomes the easy thing to do. One of my friends, late friends I say now, who used to work on the maternity thing on prompt, the professional training in obstetrics, they used to say you have to make the right way, the easy way. And, when we're talking about devices and procedures in primary and community care, we've got to make it easy for those clinicians or all healthcare professionals to do the right thing.
And on that note, I was a bit surprised to learn that it isn't a standard part or a compulsory part of nurse training to have training on sexual and reproductive health, and I wondered why that was and whether steps have been taken to make it universal rather than potentially something that can be left out.
Well, I'm not that au fait with the nursing curriculum, but the last time I did look at it when I was at the RCOG as president and I was collaborating with the Royal College of Nursing, I thought that we'd made big steps in moving forward and taking the view that, half at least, perhaps a little bit more, of all the patients a nurse will look after will be female, and that we need to understand what their needs are. But the fact that we're having this conversation means that we haven't got it right. So, as I say, I think we have to make the right way, the easy way, and we have to provide training that's easy for that person who needs to get the training. And I think the health hubs are, not only are they a good training resource, but we've also identified in the hubs, in the pilots that we've assessed, that they're a really good workforce retention tool as well. Because if you're in a bit of a burnt-out state in my specialty, it's actually much nicer working in an environment where everyone says, oh yeah, come on, we can get that sorted out for you, no problem. It's actually a much pleasanter way to work than always saying, no, we can't do that here.
Thank you very much.
Thank you, Nia. Kevin?
Yeah, I just think about how complicated gender relationships in nursing are. They're actually really complicated. But I wanted to talk about, just briefly, Lesley, about disabled girls and young women. I know you were asked to look at engaging with groups who maybe were underrepresented or underengaged within the 2022 Women's Health Strategy. Have you managed to have engagement with disabled girls and young women? And what did you find out, particularly about any barriers that they face to accessing healthcare?
Well, Dr. Nigat Arif, who I think you've all met, she and I have founded something called the Women's Health Collective, which sits under the umbrella of Wellbeing of Women, the charity I chair. It now has 80 representatives from marginalised groups. And this isn't just cultural or religious or ethnic groupings. This is also disability, including neurodisability and every form of physical disability. You'll be glad to hear we've also got quite a few men on this Women's Health Collective because they're really interested in working with their communities to promote better health for girls and women. So that's not the answer, but happily we managed to, due to someone's ingenuity, not mine, get a big grant from the lottery fund. So they're now funding this for the next 3 years. And that means that we're able to offer travel expenses and, in some cases, childcare expenses and a small token stipend for those women who we want to reach and be much more efficient at reaching, as opposed to saying they're difficult to reach. We've adopted the view, well, actually, no one's difficult to reach, but some people are much easier to ignore than others. And it means that we can get people, say, for example, from the north of England to come to a meeting in person, which they wouldn't be able to do otherwise. They wouldn't be able to take the time off work or their caring responsibilities or the train fares. So that's a way forward, and I'm hoping that already we've used them when I say use them, we've worked with them to produce various pieces of information, some of which I've just sent into the strategy. So we had a meeting in, was it October? October time, where we had about 40 of them come to a venue And we sat down and did workshops throughout the day, and we asked them what they wanted, not what I thought they wanted, but what did they want. And we've just submitted that information. And it's very rich information, it really is. And it's come from all sorts of different walks of life. And I think it's quite awesome, actually, when you read what some of these girls and women have been exposed to. And I think in many cases it's not because people, don't know or are ignoring them, but just hadn't realised that that was their social or their socio-economic setting, and they need to be made aware of that so that they can take the right steps to make it correct. So I'm hoping going forward that this Women's Health Collective will have an increasingly important role in informing us about what the women and girls out there want, as opposed to what people that look like Sue and I think they need.
And if there's anything you could share with us after this, that would be really helpful.
Very happy to,
particularly around any differences between women with visible disabilities, physical disabilities, and then the non-visible disabilities, such as, and maybe people who are neurodivergent as well.
So the neurodivergent representatives we've had, I've learned a lot from, because they really do have problems. And one of the other things I think has been interesting is it's linking it up with, and it is connected, heavy menstrual bleeding, because women who have very, very heavy menstrual loss every month, 12 times a year for many years of their lives, they often get iron deficient. And there's an emerging evidence base now to show that when your serum ferritin goes down, so not the hemoglobin that we've got all the point-of-care testing for easily with the pinprick, but ferritin, which we need to get a point-of-care test for, when that goes down, your iron stores, you feel exhausted and you feel washed out and you feel unwell. And there's now data showing that it increases, it may be one of the factors that's contributing to this increased incidence of ADHD and autism in teenage girls. And it's actually very, very easy to treat, but you've got to diagnose it. So it means, you've got to listen to the symptoms and then make the diagnosis, not just assume, take the diagnosis and then work backwards.
I imagine if you're very tired, it's much harder to mask, would be my hypothesis, but anyway, that was fine.
Well, the other thing is that the other thing to ask them is your hair falling out? And invariably this young woman or not so young one will say, how did you know? Mm-hmm. But hair falls out when your ferritin levels are very low. And again, the normal ranges have been constructed in men, and we need to understand that a normal range in a man who's not losing iron store every single month are very different to what women need.
Thank you, Kevin. Dame Lesley, you talked about the kind of problems with the long-acting reversible contraception fittings, such as coils or the implants, and that's been really broken for years. One area that we've heard that is really damaging for women is for lesbians' access to menstrual health, and particularly the discriminatory impacts that they're having. We've had examples where lesbians have had to lie that they are actually having sex with men in order to be able to get access to either an implant or to a coil. Is there any steps being taken to end this discriminatory impact on lesbian women and women who do not have sex with men?
I come back to my comment earlier, if you walk through the door and you say you want something and I'm able to provide it, I'm going to say yes. But I mean, I've never met a woman who's I haven't had that experience, and I don't disbelieve you if that's what that you've been told. I find it shocking on all sorts of levels, intellectually, emotionally, and professionally. Again, we come back to the fact that possibly the key to this is not always thinking, we've got to train the healthcare professionals better, but we've actually got to get girls and women to understand what they need to do to be effective advocates for what they need.
And I think many women and girls have found the effective advocacy on this one is actually to lie and say, because otherwise they won't get access to the treatment that they need. And I'm wondering if the NHS is taking any steps for this, particularly, I mean, this isn't just a problem for accessing hormone-related menstrual health, but also a problem when it comes to even smear tests, for example. We'd heard evidence earlier in this inquiry about that. And I think, is there anything that's being done in the same way that we see with the racial discrimination? Is there any work being done for lesbian, bi women, and also trans men as well, for a greater understanding from NHS services that when somebody walks through the door, they get the treatment that Dame Lesley has expressed?
Yeah, completely. And I think what you were initially talking about was the kind of commissioning chop-up that people are experiencing, which chops up their care. And no one should have to lie for care or have to go around different houses in order to find what they need. So completely recognise that point. And, lying about anything to get care is not acceptable. I think that we are tackling this. So with the neighbourhood framework and neighbourhood good practice is absolutely at the core of that. And I think delivering good neighbourhood care is about collaboration. And what we're talking about is actually getting the people together, the leaders, and saying, how are we going to solve this problem? We know everybody knows it's a problem. And actually in some local areas they've found solutions to it, and they're not very complex solutions, but it is about getting people around the table and just saying, there is a really, really clear solution to this. We can work out the exchange of money, and I think it's driving it forward and getting people to own that. And absolutely, in the sort of good practice guide, we'll start to shape out some ways of thinking about that, and then we're working with the regions and the ICBs to think about that in more depth and measuring the outcomes as well.
And when will you expect that piece of work to be rolled out more widely?
So it's imminent, I would say. We will be we'll be rolling out, meeting with the regions in the next 6 months, all of them. And then having those conversations.
Excellent. Would you be able to feed back to the committee at some stage about the progress?
We're doing a roadshow, aren't we?
We are.
You two are always a double act, are you?
Quite often,
Very effective, because we've got two different organisations that didn't used to talk to each other, and now they're talking all the time.
Brilliant. It's very good to see. I'm going to hand over to Alex.
Thank you. Just very quickly, I wanted to end with some questions around women's health hubs that we've talked about a little bit, so I'm just going to kind of cut straight to the chase. Is there a risk that government's reforms around, scrapping NHS England, etc., are going to threaten the sustainability of women's health hubs?
So, shall I start with that? Yeah. So, first of all, the work goes on. So the reforms are happening. NHS England is combining with Department of Health, and we continue to do that work. I think that in terms of women's health hubs, obviously there's a time of change, so there's a little bit less bandwidth probably for people to do things at the moment. I think that makes it more challenging. However, I do think the drive, so there's a number of drivers, aren't there? There is the secondary to primary shift. There's the elective waiting lists, and we absolutely know that in gynecology these are demand driven. So we need to find a solution in the community in order to also tackle that. So there's a lot of reasons why systems will want to find that solution. Hubs are a cost-effective solution. And so I think that the problem is that they were small kind of pilot test of concept. And the challenge now is the sort of spread and adoption. And so there's lots of examples of good practice that show that this works for waiting lists and for people's kind of care. And so it is just the challenge of the sort of double running, trying to deal with the waiting lists and then try and build a transformation. Transformation takes time. So I think the will is there, and I do really believe that, I've been speaking at the RCOG, I've been speaking with lots of different parts of the system. We speak locally, don't we, very frequently. There's a lot of will in the system to do it, and there's plenty of primary care professionals, both nurses and GPs actually, who want to diversify their portfolios, so they bring the expertise, and then they go back to their primary care practices, and then it gets spread, and then people also learn from it. So I think it is a transformation that will bed down. I really do believe that, but I do think it's going to take a bit of time. And I think the system is worried about how to fund that change. We'll be thinking about what funding, is within the sort of financial frameworks in order to try and drive those shifts. But of course, there's still the waiting list to get on top of. So, there's going to be a time where that's going to be a bit more tricky.
Thank you. I represent a semi-rural constituency where public transport is threadbare at best. And we don't have even a part of a conurbation. You see what I mean? We have lots of small towns and villages. I can't imagine it would be an extremely long time with many women's health hubs opening up before we got one in our constituency, put it that way, my constituency. And there are many areas in the UK that are even more rural with even more threadbare public transport than my area. What is the plan for areas like that in the UK so that women there are supported, and how long will it be for that kind of filter down, bedding down process to take?
So it shouldn't have to filter down, it should be, but I think that's absolutely recognised, and therefore it's much more a neighbourhood approach. So how do we ensure in rural neighbourhoods where people can't get to places that they have somewhere they can go, but they don't need to go to one particular place for everything. So local systems, so we've got a set of clear aims. These are the things that really, really need to be delivered. How that happens is really dependent on geography, populations, what's already there, what skills are in the system. So it really requires that kind of mapping that and then shaping it up so that it will reach you as well. Thank you.
Thank you, Alex. And thank you very much for your patience with our delays in voting. I have one last question. January is Cervical Cancer Awareness Month. We have seen other countries across the globe be able to eradicate cervical cancer, yet we are falling behind. The last 3 years, we've seen 400,000 children leaving school without receiving their HPV vaccine. In some areas, such as Lambeth, take-up is as low as 38% in Year 10 girls. Is the NHS on top of this importance of increasing the uptake?
Well, all of us are talking about the elimination programme, because this is a preventable disease. There aren't that many cancers that are preventable, but this is preventable, well, at this moment in time, should I say. So I think that's really important. We've got to overcome vaccine hesitancy as well. I think my solution of that would be I want Taylor Swift to stand up at the beginning of her concerts and say it's really cool to have your HPV vaccine, go and have it. Because I'm sure she'd do it if somebody just knows her well enough to get to her. I'm sure
not on my call list, I'm afraid.
Well, it's not mine. Otherwise, I'd have done it. But I mean, it's a good example of she's a cool figurehead for that particular demographic. And we've got to do things like that. And then there's the catch-up programme, isn't it? I think it started last July, and it's going on, I think it's till March 26th. But presumably what we will need to do, having looked at the figures, and we're sort of behind where we wanted to be, is continue that programme.
Absolutely. And I think the message really, hopefully, is that a parent would do anything to protect their child. This is one of the easiest ways to prevent a cancer that we know is preventable. Sorry, Dr. Sue.
Yeah, so I was going to sort of build on those things. So we had Harry Styles actually doing a campaign on that. So don't know if that chimes. But yes, so the communication is really important, and that there's quite a few things happening in terms of the communications and trying to get the message out to people. I think also bearing in mind that some of the people that are really important as well are the never screened. So those are the people who, and we know that there's lots of inequities in terms of who does and doesn't attend. So, and you probably know that there's the self-sample test that's being rolled out, and that's going to be sent to people who haven't come for a smear in they're 6 months overdue. So that's going to help pick up some of those people who might never have come because it's embarrassing and difficult and inaccessible.
Can people request that?
Can you request?
People request it.
Can they request it? So at the moment, it's being rolled out for people who also in some areas for people who find it very, very difficult to have a smear. So it's a sort of incremental rollout.
And also there are quite a lot of areas where women have to go to a sexual health clinic in order to have a smear. And if you're a Muslim woman or you're an Orthodox Jewish woman, you're not going to go to a sexual health clinic to have that done. So I think we have to make it much easier and use every episode count. What's the word I want? Every contact count. Every contact count. Thank you. Every contact count, and then use that and be very sort of opportunistic about. Well, have you had this? And we must get it done. And it comes back to the comment I was going to make earlier to your colleagues just left, and the thing about the waiting list. Sue and I did this piece of work for Baroness Merrin last year on looking at the gynecology waiting list, and you know what the headlines are, 600,000 women. But what I think really shocked the two of us was that 85%, or more than 85% of them, were not going to need anything invasive or anything in a hospital. So you have to ask, well, why are they on the waiting list? And I think when we wrote our forward, one of the things that we said was, this is not a bit of tinkering around to make every bit of the system a bit more productive. This is about a radical rethink of moving, and shifting left into the community. It's ludicrous that 85% of 600,000 women are waiting for long periods of time for things that they don't need to wait at all for.
Absolutely. I think that is a great point to end. Thank you very much for your patience again and your expertise and sharing your knowledge with the committee. We're very grateful. That brings the session to a close. Order.